right, good afternoon, everyone. Now that we're post-lunch, everybody's awake, ready for the afternoon? Exactly. So this session is really exciting. Go ahead and come on up. The speakers can come on up and have a seat, and we'll go ahead and introduce the speakers once we get started. So this session is going to be application of big data, comparative analysis to increase risk prevention, and these are opportune examples of doing this exact thing. So next slide, please. Oh, right here. Oops. So one of the things that I'm pulled to this organization is that it kind of does it all, right? And I was the 2015 Wiley Scholar almost a decade ago. Can't believe that. But one thing that Vascular Cures does that I think is quite amazing is that not only does it encourage research and data, but it's also trying to branch out into all other elements that are critical in order to build effective collaboration and integration and implementation, as we've been discussing today. And one of the things that I wanted to talk about is how do you do this new ventures and implementation and intellectual property? And as we hear the speakers talk about their data science and how they're implementing it, one thing that we could discuss is how are we implementing these other aspects into these paradigms so that it does reach the population that we want to get it to. Oops, wrong way. So this is a fantastic book, and it touches on some of the concepts that we've been talking about throughout the day. We all get the sense of excitement in these discussions, right? We feel that there is something new happening with this new data, with this new type of science that we're trying to figure out and that we're trying to implement. And this book talks about how these types of paradigm shifts occur. And as someone said earlier in the day, these typically don't happen linearly. There's accumulated science, and then all of a sudden there's this fast shift. And it's this aggregate science that happens over time that kind of generates these anomalies, and we start seeing things are not adding up. The old paradigm, the thing that we've been talking about of just testing people with ABIs and hoping to capture the right people, that's not good enough. We got to do more. We got to figure out what their demographics are and where the disparities are. And as soon as we start noticing these anomalies, then we realize how to replace them with something better, a new paradigm. And the scientific community is the one that decides what this is and how to implement it, and also the ethics around it, and how to accept what is new as new truth. And that's, I think, what we're doing today in our discussions, is figuring out how we're going to do this with AI and big data. And our hope is that these paradigm shifts are not going to occur by just a standard route, generating a great idea, getting a grant, discovering something new, and then publishing it. What we're hoping is that this is not just going to be a cyclic pattern, right? That this is going to actually translate into practice, and we're going to find a methodology for implementation. And so how do you do that? And one of the things that we've explored at WashU is how do you integrate this into our daily practice and our training of researchers? And we have a training program that actually looks at these types of things to allow people early on in their research careers to look at how do they go ahead and patent their ideas, license them, and even start them in a commercial sense in order to get them implemented. And what we realized is that one of the first things that you need to do is you need to think about the ecosystem that's related to your science. And so, yes, when you have a great idea, you're going to get a grant, and you're going to try to get funding, and you're going to pursue discovery. But you also have to think about what is the intellectual property that goes into this, and how will you be able to build a foundation for this science so that it could be protected and potentially licensed. And how do you develop a way to educate around it? How do you get outreach and buy-in from the public? How do you engage with industry and seek additional funding and be able to seek opportunities to be able to develop these concepts further for commercialization? And the second thing is, how do you build synergy around your science? We're going to hear from these speakers about how they've built teams around their ideas and how they got other people and collaborators excited about what they're doing. And what we've seen time and time again is that if you work in a silo, the time to integrate and impact and implement is far longer than if you work in a synergistic effort. And I give you an example here of like a medical expert, a scientific engineer, and a business legal, but this could be something entirely different. Think of CAR T therapy, for example. These are molecular biologists, immunologists, and implementation in oncology, right? Different fields that are synergizing to be able to develop a new therapy. Think of the COVID-19 vaccines, right? We were talking about, molecular biologists again, vaccine biologists, but industry, and synergizing to be able to bring a vaccine in an extremely rapid turnaround. The third thing to think about is the adaptive clinical research framework. Oftentimes when we conduct clinical trials, as we've seen, is that there's a design, and we conduct it, and then we see what the data shows, and we analyze it, and we publish it, right? There has to be some sort of adaptive design. As we talked about earlier with some of the AI models, there has to be some sort of methodology to reassess it as you're developing that scientific paradigm and that scientific question, and reassess, are we asking the right questions? Did the data make any sense? Should we change the question? Should we reanalyze it in a different way? And perhaps that will provide you with better data sets and opportunities to analyze earlier before you go down blind alleys. And then the fourth thing is to harness the large data. And again, this is the topic of the day, and I'm not an expert at it, but as we're doing this, there's the classic methodology of being able to ask a hypothesis and test it out with experimentation. But when you're incorporating big data into it, these hypotheses generation can also be re-implemented into specific questions in order to be able to redirect where exactly we want to analyze the data. We talked about, figuring out what potential biases come out of our science. This could be done in this cyclic fashion. As you're analyzing this data, you're noticing where these biases are, reintroducing new hypotheses, and so on and so forth. So with no further ado, we're going to go ahead and hear from the experts, not me, but we're going to first start with a talk about multi-institutional database discovery, an example from Stanford. Please come up and introduce yourself, and then we'll go to the next speaker after that.
Awesome, thank you. Awesome,
I think they're going to stop my slides and start new slides.
Perfect. Hi, good afternoon, everybody. My name is Aiden. I'm a general pediatrician and a clinical informatics fellow physician at Stanford University. I help teach some of our digital health classes at Stanford as well, which are led by Dr. Oliver Alami, who's a vascular surgeon, which is why I'm here in front of you as a general pediatrician. We've recently gotten access to a really neat multi-institutional database through Epic, and we've learned some really cool things with it, and that's what I'm going to go ahead and show you today. Awesome, thank you. So first, disclosures. What we're about to cover is a commercial product made by Epic Systems, as you'd imagine. I have absolutely no financial disclosures or conflict of interest to report. There are plenty of upsides and downsides to Epic, and I'll be the first one to tell you that. But we have learned some really interesting things with this tool, and it's something that all of you could get access to. So I think it'd be really interesting for everyone to know, to be up to date on the latest. So what we'll talk about is I'll give you a quick overview and history of Epic Cosmos, data available in Cosmos, a few example analyses that we've done to show you what it can do and to contextualize it around what you might be able to do, other clinical use cases they've got, and then suggested next steps for research. So if you know anything about Epic, they brand their products in really fun ways, and they follow a space theme. So like their new biggest multi-institutional database is called Cosmos. It's a database of all patient data from Epic institutions, and it's shared through Care Everywhere. So if you're an Epic customer and you can see patients' data using Care Everywhere, that's how they get all the data from these institutions. It's an opt-in thing, which institutions will opt in to share their data with Cosmos, but in exchange, they also get access to all the de-identified data to do their own research or clinical analyses. They have data from all 50 states, and they say Lebanon on there, but it's really a small portion of people. So those 270 people are all from the US, and if you think about the fact that the US is like 300 or 330,000 people, or million people in it, it's a lot of the US that's represented here. It's also pretty crazy to think that Epic has that many of the US in their healthcare records. The data set is decently representative of the US Census, for your academic purposes. There's maybe a little more representation of publicly funded insurers, payers in the mix, but other than that, it's decently representative of the US Census with respect to age, race, ethnicity, coverage, and social vulnerability. This is a quick demonstration of what is in Cosmos. So it's, if I could summarize it, it's essentially everything that you would use for clinical care, and then some, like all of the things that the nurses may collect regarding social determinants of health, smoking status, you talk about different levels of income, payer status, all that stuff is stored in Cosmos. So I thought a neat way to show you an example of what we've done with it is to try to recreate research. So I'm not a vascular surgeon, but I think this is a decently reputable journal in vascular surgery. And I went to the front page and I just found an article that looked interesting, which is on the lower right over there. Risk factors for abdominal aortic aneurysm in patients with diabetes. Some of you may know Dr. Cho. So then I went through and I wanted to see what are the results of the study and see if I could just recreate it using this database. So the main results were that cardiometabolic diseases, abdominal obesity, and smoking were associated with increased AAA risk in patients over, and then along with patients over 65, male sex, and insulin use. We all know that these are risk factors, but I thought it'd be interesting to see if we can recreate the results. So here's the analysis over here. What I ended up doing is I broke down all the patients by risk factors first. So I grabbed all the patients with coronary artery disease. That was my proxy for metabolic disease, obesity, and type 2 diabetes. And then I subset it out, the population of America that has none of the above. And then I looked at, out of those, how many people have a diagnosis of AAA. As you can see, we recreated their results right here. This is the prevalence of AAA in each of those populations. If you wanted to spend extra time, you could get odds ratios and hazards ratios as well. Another one of their main headlines was that oral hypoglycemic agents, in particular metformin, TZDs, and sulfonylurea, may contribute to decreased risk. But they said may. And if you look at the confidence intervals in their study, it was really questionable on whether or not this contributed. So on the left, on the blue bars, you'll see the medication classes of TZDs, sulfonylureas, and metformin. And on the y-axis is the prevalence of AAA among those groups. And on the fourth bar is none of the above. That's like type 2 diabetics who are not on any of those meds. And as you can see, it's like questionable on whether or not the prevalence is decreased. But it does follow some of the arguments that they make about metformin and TZDs. Then I thought, well, I'll take their analysis one step further. What if I look for like a complication of diabetes to suggest like maybe diabetes is uncontrolled? So on the right is the green graph, and those are patients with diabetic retinopathy in the US. And on the x-axis again are all the different medication classes, and on the right, none of the above. And as you can see, just barely it does make a difference on prevalence of AAA, which I thought was really interesting. All of this took me about probably 15 to 20 minutes to reproduce their research findings. Another example, so I'm a pediatrician. Of course, I'm going to show you an example about kids. This is a really important paper looking at the impact of race and ethnicity on outcomes of liver transplant patients in kids. One of the main headlines that they found is that African-American children are less likely to have living related liver transplants instead of deceased donor transplants, which is a really sad fact to grapple with, but it is important for us to look at too, to see what other things can we look at in Cosmos to understand it. We represented, my colleague and I, Nick Marshall, took a look at the database, and sure enough, if you look at the third one from the left, those are our African American and Black children, and they have much lower risk or much lower rates of receiving deceased or living donor transplants versus deceased donor transplants. If you look at wait times, which was another part of the study, if you think about referral to transplant time, the blue bars are wait times of 100 days or more. The green bars are of 100 days or less. And as you can see, Native Hawaiian and Native Americans have proportionally less time in the less than 100-day category. So do our Black and African American children. I think this is really important because it shows the impact of wealth and access to health on health outcomes pretty clearly. And we were able to do this, again, in like 15 to 20 minutes. Other use cases that I think are interesting for you to know about, they have something called lookalikes, which is a way for you to compare the metrics of your patient to patients exactly similar to them in other institutions. So let's say you have a patient with a really rare disease and you're debating on between medical versus operative management, for example. It'll give you the contact information for the physician if it's available, so that you can talk to them and get input on how they've managed similar patients in the past. This specific example was a patient with psychosis and DeGeorge syndrome, which they found matching cases, and I think that's in Kansas. This one's also really interesting. It's helping with medical decision-making based on large databases for common conditions. So it's similar to the lookalikes, except this is for patients with common conditions such as hypertension. So this looks at a phenotype on the left, which will go through the blood pressure ranges and the comorbidities of the patient. And on the right, it'll show history of success or failure with certain types of medication classes, which I think is really cool. On the last slide, I know I'm going a little fast, so maybe we'll have time for questions. At Stanford, we recently got access to it, and we're like grappling as an institution about how to make the most use of it, both academically and clinically. This is something that Epic has gotten a lot of interest in for research collaborations and for large-scale analyses. And if you look on PubMed and other resources, there are a lot of studies out there that specifically have used Cosmos to look at big public health questions. If you have Epic, your institution may or may not have already subscribed to Cosmos. So if you're an academic researcher, it might pay off to ask some of your informatics colleagues for access to it, because I think it's a really powerful academic tool. Granted, Epic's gotten questions about the ethics of using patient data for research, as you'd imagine. But these institutions are all buy-in to Cosmos, and from what I understand, there are specific agreements in place with patients about sharing the data. Those are the things that we've learned. If you'd like to contact us about what we've learned about working with Epic Cosmos or other large databases, you please contact Oliver or myself, and we'd love to talk. Thanks.
All right, so next we're going to have Dr. Shreen Shilhub speaking about, do we have our slides up? Genotype, surgical phenotype, amplifying the use of genetic information to drive surgical decision-making by harnessing the power of machine learning.
Thank you so much. And I do want to say I feel mentally stimulated, and I don't know if you're all awake after lunch, but this really has been fantastic. And my brain is going in a million directions, so we're definitely going to talk about Cosmos along other things. So we're going to shift gears a little bit. We're going to talk about rare diseases now at this point, but I think what you may want to walk away with is that when we have people with severe phenotypes of disease or extreme ends of the spectrum of the disease, there are a lot of valuable lessons that we can learn to apply to people with more common diseases. So if you approach this with this lens, I think you're going to see a lot of themes here that may be relevant to just the general population. And can we go back? Yeah, so these are my disclosures. These are just all voluntary positions. And for the people who don't know me, I am a vascular surgeon. I am not a geneticist, but I have a particular expertise in people with genetic aortopathies and rare diseases. So that's the space where I spend most of my time. And earlier today, we had a speaker that talked about speaking different languages, and I feel like I do live at that intersection between genetics and vascular surgery. So with that, I'm just going to briefly touch on the aortic and arterial genetics landscape, and then briefly touch on genotype, surgical phenotype, and how that affects our surgical decision-making, and what are the challenges in 2024 in terms of incorporating this onto a practical level. And I'll touch on the research methodology that I've used, which is engaging patients, because that is one particular population that's been challenging to study, and challenges. minding the gap, as you're listening, there's going to be a lot of gaps still in our knowledge when it comes to care of this patient population, and I'm hoping that the methodologies from today potentially can give us an opportunity to mind that gap. So when we're talking about genetic aortopathies, generally speaking, people are thinking about monogenetic variants, or they're thinking about Marfan syndrome, Loeys Dietz, and vascular EDS. In terms of frequency, Marfan syndrome affects 1 in 5,000 people, and vascular EDS affects 1 in 50,000 people, so there are about 7,000 people in the United States living with this disease. So kind of rare, but again, remember it's a rare disease with a severe phenotype that we can learn a lot from. But ultimately, what these diseases cause is fragmentation of the elastic fibers in the aorta, loss of smooth muscle cells, and accumulation of proteoglycans. And it makes the aorta very vulnerable to dissection and aneurysms. How common are they? If you look at IRAD, which is the largest database on aortic dissections that is present in the world at the moment, has almost over 10,000 people with type A and 5,000 with type B. You can see that 10% of the population, whether it's type A or type B dissection, have a family history. So not necessarily a known genetic thing, but just have a family history. It tells you it's genetic. And then if you look at Marfan syndrome specifically, 4% of their population has Marfan syndrome. And there are many ways that we can recognize genetic aortopathy in clinical practice, and I put examples of physical features as well as radiological features. And this is really applicable to something like Cosmos that you're saying, like, can we find these people that have not had genetic testing? The other thing in terms of AI, if you look at the features of the facial features up top, these are people with vascular EDS. There are people currently working on tools to scan the face and then try to identify the genetic pathology in that. Now, that can open a whole can of worms about ethical issues with facial recognition, but that is something that is happening in the genetics world where they're trying to identify people earlier in their disease process. And then from a radiological perspective, this goes back to there's an opportunity, again, based on radiologic features to identify these people a priori. Again, 20% of the population with aortic pathology have a family history. This is really important because a lot of people don't know this. We'll see people that, well, I'll tell them that aortic disease is similar to cancer. It runs in families, and sometimes that is news to them and the first time they've heard it. I still have vascular surgeons who tell me this is the first time they recognize that. So I think this is really important to know. The other thing is 50% of the variants are de novo, meaning somebody has to be first member of the family to have this disease. So absence of family history doesn't rule it out. And then the other thing to update people on is that the ACC/AHA guidelines do recommend genetic testing for people with aortic disease if they present younger than 60. So younger than 60 is considered young, and therefore they qualify for genetic testing, and certainly if they have features. So then here's the question, does the type of genetic variant matter for surgical decision making? And I'm here to tell you that absolutely it does, and we need to now change how we think about our approach to surgical disease in terms of things that are operative and how we plan. For the surgeons in the room, this is actually intuitive. I'm just pointing out the obvious because people know that there's variation in the quality of tissue. And in fact, if you're not a surgeon, you're primary care, maybe our pediatrician who examines kids, there's quality in the tissue texture, I mean, the skin texture among kids, right? Some people have really soft skin, some people have harder skin. So that, again, the aorta is similar and no different. So we do know from the natural history studies that there are variations among the different genes. I gave you examples of 3 syndromes. They definitely have some variations between the diseases, but also within a given variant, if you have, for example, type 3 collagen gene variant, depending on what that variant is, there's variation in how they present. So this is that example of the COL3A1. This is the gene that causes vascular EDS. We know that, for example, if somebody has a variant that causes a gene to be silent, so they're only producing half the amount of normal collagen, that person has a different phenotype than somebody who has a variant that causes specifically something called the glycine substitution, and I have a slide on that as well. But the natural history, the time to time of disease manifestation is variable. And what I have learned over time is that if a particular genotype causes earlier disease onset, it stands to logic that they probably have worse tissue than somebody who doesn't, that has a later manifestation. So this is the example. I've asked ChatGPT to tell me what they think, or what ChatGPT thinks collagen triple helix looks like. But the collagen triple helix in type 3 collagen is literally oriented as a glycine and an XY. So it's a glycine and then an amino acid, and it repeats itself repetitively. So if you were to take glycine, which is the smallest amino acid, and you put, let's pick the glutamine amino acid instead, you can imagine now that the capacity of that collagen molecule to fold in the normal way is now impaired. And in fact, we see that on electron microscopy where the endoplasmic reticulum gets chock full of this defective collagen and it cannot secrete it. So now you can say, okay, well, based on that, it stands to reason that if you have a small amino acid, perhaps your phenotype is less severe than somebody who has a large amino acid substitution. And again, that slide deck on the right side of this left side of the screen shows that in natural history studies. So now you can say, okay, now I can look at your genetic variant and make some prediction that this is what's going to happen. Similarly, this is work led by Diana Milowitz, who's done a ton of work in the genetics world using this multi-center consortium, looked at these variations between individuals who have smooth muscle cell variants as well as TGF-beta variants as well. Again, the natural history is different. We looked at it from an aortic dissection perspective where we said, is there a difference? Like what if I don't practically know what your genetic variant is? Or what if you are one of the 70% of the families that clearly have familial aortopathy, but we still don't know what you have? Can I use that information? Can I use your family history as a marker? And actually, when we compared people with familial, non-syndromic familial, compared to people who have syndromic variants and versus people who have sporadic variants, those people with the family history fit in the middle. They are in the middle in terms of how high their blood pressure was when they dissected. They are in the middle in terms of how old they were when they dissected. So they were older than syndromic, but younger than non-syndromic, for example. So that, again, even just knowing that variable makes a difference. The AHA-ACC guidelines do include now a gene-specific approach. And in terms of what we have for data today, we are able to make some comments on Marfan syndrome and Loeys-Dietz, but at that time when this came out, vascular EDS, there was positive data and recommendations, so really no clear guidelines. So going back to the vascular EDS, the most severe phenotype, these are 3 people that I've operated on, all had abdominal aortic aneurysms, all needed open operations. And that was the beginning of me kind of mulling over this idea as can we translate the natural history information to an actual thing that matters to surgeons? Like, is the tissue really different? Not just the external appearance of the person. And indeed, the tissue was different between all 3. The person who had the large amino acid substitution had the worst tissue, when we operated on this particular person that was very fragile and really was difficult tissue to sew into, if you will, compared to the person who was older at presentation and had a null variant, had a better quality of tissue. We also, this idea can translate to what I call biological twinning, meaning if there's a family member or somebody who has the same variant who's had an operative repair, information from how that tissue handled is actually relevant to the related family member, similar to what you just showed in Cosmos, where like people like me. Like if we can have that information, we can actually help guide patients to understand how their aorta will remodel post a stent graft or how it would handle from an open operation perspective. What else do we have for data? The largest series right now looking at TVAR in this population was multi-centers, 171 patients, but it didn't have a lot of the genetic diagnosis. Only Loeys-Dietz had genetic diagnosis. Everybody else was clinically diagnosed. So it's useful information in the sense that you can see that there's variation by type, but it wasn't so useful in the sense of like I really wanted to know what the genes that affected were specifically. But this is my conceptual model. So when I talk to patients, I say, this is my conceptual model, and I'm looking for smart people who are working in AI to see if we can prove this principle to say, is the gene correlative to the tissue tensile strength, with FBN1 being the best in this group of genes and large amino acid substitutions and COL3A1 being the worst. Okay, so where are we now? We know that the genetic testing technology is improving. This is ChatGPT generated timeline of genetic testing advancements that shows how this has been progressing over time, which is great for this particular population. The more we can test, the more we can identify, and the more we can integrate with AI, we can develop an evaluation of these monogenic diseases or polygenic diseases, which a lot of them are polygenic. So people are talking now about polygenic risk scores. And I think it's really important to understand that not one size fits all. Just because you have a particular variant also has to be in the context of your epigenetics and your environment, because these also interplay in terms of how severe the disease manifestation can be. So I think it's really important to remember that just because somebody is born with a certain book of DNA, it does not doom them to that trajectory. It just gives us an idea of where they are on the risk spectrum. And then there are other things that can be done to modify that risk. So that's really important. The human factor matters a lot, though. because there are still wide barriers to adoption of clinical genetic testing. The technology has been around, the tools are around, and the cost has gone way down. Again, to remind you, when we look at the Human Genome Project back in 2003, it cost $2.7 billion. You can now sequence people for less than $1,000. So the cost has gone way down. And there are laws regarding genetic discrimination, but that's still a consideration for people who are choosing to get tested and concerned about coverage of insurance or discrimination by their employer, as well as the psychological impact, because now they have gone from somebody who's living with a healthy lifestyle, and all of a sudden they have a disease label. So that's why I think that's one thing we've learned a lot from engaging with patients. We also know that there are disparities in genetic testing by race, that if you are of an African American descent, you are less likely to be offered genetic testing or less likely to receive genetic testing. And that's actually relevant. And the eye-opening for me was about a decade ago, where we had a patient who had he was young when he had his dissection. And the question was, is there a family history, or does he have any syndromic features? And the response I got from the fellow at that time was, well, he's black, so he probably doesn't have Marfan syndrome. It was a very interesting commentary to say, and if you look in the genetics textbooks, all the pictures are of people of Northern European descent, and so it's just that whether it's a conscious or subconscious assimilation that, oh, well, it can't be present in other races, which is not true, and we know that that's not true. There's no biological reason for it to be true. In terms of what are the, again, human factor barriers, we asked the vascular surgeons through a survey to understand what are the barriers. So insurance coverage and costs were barriers, but lack of access to genetic counselors and lack of knowledge were also perceived as somewhat of barriers, and I'll comment on those. We are going to have our inaugural vascular genetics symposium coming up in a year specifically to address the knowledge, and this is going to be designed for vascular trainees specifically so that they're more knowledgeable about vascular diseases. But we still have a problem in terms of how we're training our medical genetics workforce. You can see from this paper that a third of the positions went unmatched. So that is a problem. And in fact, if you talk to a lot of people, they'll say, if they are not in an academic center, they'll say we have no access to genetics or people that can help us. So that is an area where AI can come into place, and I'll show that later. The other thing is variants of unknown significance is a problem. The more genetic testing we do, and in populations that are underrepresented, there's a chance that the variant will be classified as a variant of unknown significance, just because we have no way to predict the biological impact of that variant. Also, that said, the direct-to-consumer genetic market testing is booming. This is a multi-billion-dollar process that is happening, and people are interested. Those who have the means are interested. And I'm showing this here because I just actually went through this. This particular company offers it specifically for dyslipidemia and atherosclerotic vascular disease. So they have this panel, and they're looking at all these markers that are associated with Lp(a) and hypertriglyceridemia, et cetera. This one out of pocket is about $500, and it will send you a 45-page report with all the variants that are known to date, along with personalized recommendations for how to manage your health. Not covered by insurance. And when we talk about disparities, it will increase disparities because people who can afford to do this will pay for this, and people who can't won't. So the future of genomic or vascular genomic research, I think there's an exponential growth in genomic data. So we do need AI tools to mill through all these data, and we need to advance our research methodologies to keep up not only with identifying disease-causing variants, but also the biomarkers that are associated with these variants. We need to be able to interpret the genetic variants and classification. And come up with these predictive modeling. The predictive model idea is not a new idea. I mean, people have talked about predictive modeling for a long time, but perhaps now the technology and the tools that we have will allow us to have functional predictive modeling that can help us personalize the therapy for these folks, and as well as predicting, postoperative complications and picking the right operation for the right patient at the right time. Other challenges have to do that our original data came from data that didn't have imaging, and we used a lot of, just clinical databases rather than imaging, and that is something that is still a challenge today to collate all these images, and that's why I was excited to hear about the vision, approach to these, that maybe we can use that as information that we can analyze. But you can see also on the bottom, from a research priorities, patients ranked genetics and how that affects their health as the #2 priority, in addition to education. We have engaged patients. I'm running out of time, so I'm going to wrap up quickly. But I wanted to say that we use patient engagement as our tool to address this disease process and these disease processes. And a lot of the patients were interested in sharing their data. And that led to developing this collaborative, which is a natural history study. And now it's expanded to VEDS-like conditions. So anybody who has a genetic variant but is interested in joining the study can join us. And you can see the majority of the populations from the West Coast, but we have, and the US, but we have some people from around the country as well. And this is an example of a paper where it came out talking about specifically the vascular pathology in a vascular bed and how to manage it. But I wanted to highlight that box in the middle. So you can see that we have 557 individuals with vascular EDS, which is a very large cohort for that particular disease. But look at the racial distribution. 95.6% are Caucasian or Northern European descent. So that tells us, again, we're not testing, we're not recognizing the disease in that population. So as we think of vascular surgery, I always think of chatbots, and I wanted to hear more about using that particular technology and priming people before they come to clinic, or to get their genetic counseling, or to get personalized recommendations. But that is how I see that at least practically working. And then you can see that there's so many aspects when it comes to vascular genetics that we can incorporate it, including, as I told you before, how do we predict disease progression and the right operation for the right person, as well as tailored therapeutics for them. This is ChatGPT's interpretation of all the barriers to multi-system data harmonization and imaging repositories. I just said, make me an image, so that's what it looks like. Indeed, that's what I feel I've been dealing with for the last 10 years. So at least ChatGPT is on bar with that. And I appreciate your time and attention, and I'm looking forward to the discussion.
All right, what a terrific talk. So next speaker is Dr. Leah Ann O'Banion, and she'll be speaking about the champions identifying and characterizing vascular deserts using large data analysis.
All right. Thank you, everybody. And Isabel, thanks for having me. I want to, first of all, before I start, say that none of this would have been possible without the help of Cures. And a lot of people in this room who are part of our team who have made this a reality. You know who you are. Those are my disclosures. So I think all research kind of starts when you identify a problem. And so, when you think about the problem we have here is that we have an aging population. Anyone who's a vascular surgeon in the room knows that we get called more frequently for intraoperative rescue, and we have insufficient supply. Surgeons are retiring. There's not enough trainees. We're all tired. And what does that result in? A huge deficit of vascular care for the United States. And to compound on that problem, vascular surgeons are practicing in a fraction of the United States. You can see concentrated here on this map where vascular surgeons are practicing, and you see the huge light pink areas where it is devoid of vascular surgeons. Most of us are in big cities and confined to the coastal regions, which is part of the large problem that we're facing. Another big problem that we have is that we're looking at all the patients that have CLTI or who are presenting with intermittent claudication. What we're not looking at is the huge chunk of ice that's below the sea, which is the asymptomatic PAD patients. Those are the patients who, if you think about it, those are the ones where, in other areas of medicine, we're getting annual mammograms to screen for breast cancer. We're treating them before they get cancer. But these patients, we haven't really identified who they are, where they are, and how do we stop the progression of disease so that they're not presenting in the ER with a dead toe. Making the problem worse, as you can see here, is where the amputations are concentrated in the United States. And so you can look here, most of them are not in areas where there's a vast amount of vascular surgeons. And you can see there's a huge discrepancy in the rate of revascularization in the years prior to patients actually receiving an amputation. So there's a huge variation in care that's being provided across the United States. So how do we streamline that to where everybody's getting the same care and everybody's getting good care? So a lot of people have suggested solutions. Well, why don't we recruit physicians to treat cardiovascular disease in underserved areas? That's a great idea. Why don't we teach primary care providers to provide basic cardiovascular care? Another great idea. And even further, why don't PCPs provide screening for cardiovascular disease? These are all great ideas. These have all been researched. These have all been explored. I'm about to tell you why none of them work. So you want to recruit physicians to work in underserved areas. If anybody wants to come work with me in Fresno, raise your hand. I'm happy to take you. We're hiring. It's really a big challenge. Everybody wants to work in a big city. Everybody wants to work in a metropolitan area. Nobody wants to go work in a rural area where there's nothing to do and there's nothing to see. And so you can see here in this graph that most, over 90% of vascular surgeons are operating in metropolitan areas. That leaves a huge devoid, underserved area in the United States. Why don't we teach PCPs to provide care and to provide screening for cardiovascular disease? Well, Dr. Humphrey's group looked at this at UC Davis, and she actually went out and taught PCPs how to do ABIs. She did pre-education, she educated them, and she did post-evaluations on them. What she found was that only 33% of PCPs were doing ABIs, and only 41% of them even understood what Wi-Fi was. And what were barriers to implementation? Well, they don't have time, they don't have any non-vascular societal support, they don't have any trained personnel, they have limited time and lack of reimbursement for point of care. And what she found was that when she surveyed them after doing all this training, none of them were agreeable to doing ABIs and screening in their clinics. So it's just not going to work. They're overworked, they're overburdened with patients at baseline with diabetes and hypertension. They don't have time to screen for PAD. And then furthermore, to compound the problem, and this is just going to be focusing on California, is the access to vascular care. So this is the vascular desert map that her group has worked on and published, which you can see here in the blue are all of the providers offering vascular procedures. Now that is just any doctor who might be doing a vein procedure, an angiogram, a carotid, it could be any sort of specialty. And then if you narrow it down to board certified vascular surgeons, you can see that map is getting a little bit smaller. And then if you narrow it down even further using VQI as a marker for tertiary high quality care, you can see that most of California does not have high quality tertiary level vascular care. So our question was, could we use this desert map to target populations at risk for PAD and provide access to care? And this is where Champions was born. So the principle behind this was to go out into the communities to find out which communities were in most need and partner with their local organizations and provide screening, provide BMI and blood pressure measurements, test for diabetes and hyperlipidemia, and then when appropriate, screen for PAD using TBIs, and then provide the patient with a risk assessment and educate them, because one of the biggest problems is health literacy in these underserved communities. And also providing on-site social services, community clinic, and insurance availability for these patients who oftentimes have never even seen a doctor. So you can see here we did our first couple of screenings. We targeted an area. One was the Dinuba Raisin Festival, and the other was a food bank in Poplar, California, both known to be quote-unquote unincorporated communities in California, but both with large populations, largely Hispanic, largely underserved, and in great need of cardiovascular care, and you'll see why here in the next couple slides. So you can look here, and we looked at the MSSAs for this pilot program and compared them to statewide vascular deserts as well as non-deserts, and you can see that there was a significantly lower rate of white and Asian patients, a higher rate of Hispanic patients, and a huge rate of higher percentage of patients being 200% below the poverty level. This was really kind of astounding. So it's not just that there's vascular deserts out there, but then there's these microcosms within the vascular deserts that we really need to be targeting and focusing our care towards. Furthermore, we looked at Healthy Places Index as a marker for socioeconomic disadvantagedness, and what you can see is that these patients in these specific vascular deserts have a lower mean income percentile, a lower education percentile. Very few of them are completing college. Very few of them have access to transportation. We also looked at the population on a more granular level. This is a young population that we're looking at. Very poor, 28% had no health insurance and 27% had never seen a doctor. However, 30% of them had type 2 diabetes, and of those, 10% were diagnosed on site with hemoglobin A1C measurements. And 38% had hypertension, with 40% of those being diagnosed on site with hypertension with blood pressure measurements. And interestingly enough, when we talk to these patients and we ask them, do you get pain in your legs when you walk? 21% said yes. And I think that's a really important thing to note, because it doesn't necessarily mean that they meet criteria for intermittent claudication, but they're telling a doctor that they have pain when they walk. So then who gets screened appropriately? And I think that one thing that I learned when we first started all of this was that are we trying to go out in the community and find patients with CLTI? That's what I thought we were going to do. I told Gaurav that we were going to get a bus and we were going to need to be doing angiograms in these rural communities, that everyone was going to have CLTI and they weren't getting seen. And then what I realized is that it's not that they have active CLTI, but they have so many risk factors for it, and they need to be educated, because what's happening in these communities is that they're going to a doctor, they're getting an ABI, it's falsely elevated, they're saying their feet are cold and they have pain when they walk, they're getting an angiogram and they're getting an intervention, and that's inappropriate. And so how, as we as vascular surgeons, how can we go into these communities and provide appropriate care, education, and health literacy so that they can get the preventative medicine that they need, not necessarily the intervention that they don't? So the European Society for Vascular Surgery established guidelines for who's at risk for PAD and how we should do focused screening. Interestingly enough, they recommend doing it with ABIs, and in the next few slides, I'm going to convince you why I think we should be switching that. So we recently did a correlative analysis. This is with the help of Dr. Caitlin Hicks. I'm sure you guys know her. And we essentially were able to demonstrate that TBI closely mirrors ABI and is actually an efficient tool to screen for PAD, particularly in this high-risk patient population that largely has diabetes, where their ABIs would normally be non-compressible. And I think the most interesting point about this study was that no patients that we screened had an ABI or TBI which was consistent with CLTI, despite over 21% reporting leg claudication. So these patients do not need interventions, they need prevention. So what's next? I think we want to address health literacy and the burdens of limited transportation. We really want to focus on expanding this across the United States. We want to target sites, get local interest, and then develop a toolkit that we can implement across the country. The first thing we have to do, though, is identify what specific targeted areas do we want to reach first. So we want to address insurance barriers to specialty care, partnering with federally qualified health centers. As I said, educating patients in primary care so we can limit those unnecessary procedures. This is that famous graph that Dr. Hicks published that shows the percentage of PAD cases being performed in an OBL with alarmingly high atherectomy rates. We want to get that number down. And then scalability. We want to data capture, we want to harmonize, coding is going to be really critical here. We need a centralized database that's granular to study these patients and expand it so that we can get an accurate US vascular desert map. We want to understand these populations and we want to accurately map them. And so I really think that comprehensive vascular care is and should be the answer. I think as vascular surgeons, we're responsible and we need to do this. It takes a team, but I think that if we all work together, we can accomplish this. I'm going to turn this over now to Teo, who can talk much more intelligently about data science than I can. So he's going to give his portion of the presentation, and then we'll be happy to take any questions at the end. Thank you.
Hello, everybody. My name's Teo Fleming. With most of my time, I'm actually a software founder here in San Francisco. Surprise, surprise. I am also, to pay the bills a little bit, work for Vascular Cures as a data architect, helping to basically set up things to allow the real people doing the real work to leverage their efforts. So I'm going to be talking a little bit about big data and AI, surprise, surprise, specifically really getting into the nitty-gritty details about champions and the what that means for what we are trying to do, and specifically how that relates to data and scalability, accessibility, security, and privacy. So, as Dr. O'Banion mentioned, we have these at-risk populations that are in vascular deserts, and we know that, so how do we target them? And that really begs the question, where are they? So one of the solutions is to use big data and AI to predict location. And the big, bold thing to be aware of is that what we want to do is prevention, is to be able to help people be healthier through education and outreach. So there's this big virtuous cycle of big data, which is basically if you can predict at-risk people, as well as link that with a vascular desert map, then you can go out into the community, you can collect data with the Champions Toolkit, which I'm going to talk about, and that will allow you to come around, improve prediction, as well as target for prevention. And the more you do this, the better map you get, the better you can target your healthcare dollars. So what is Vascular Cures doing very specifically? Big data is hard and very technical. That's why you have a software developer up here. Our goal is to create a scalable model that will allow, again, people like you to leverage your efforts. Instead of writing one paper, you can write 20 papers. You can allow other people, you can contribute to a data repository to allow other people to use your data and use their data in your work. And really the answer there is champions, and we're going to get into specifically all of the work that I am kind of working with others to do to bring big data and kind of a very technical topic to something and hopefully have a bigger impact than just a bunch of software that I'm doing. So data scalability. In order to have the impact that you want, you need a lot of data points, and you need them to be very consistent. One of the things that Champions is doing is to break down bureaucratic barriers. So one of the things that Champions is providing is, or writing specifically, is a playbook of how to do this, how to go out into a community and do these clinics and provide care to people. That includes consent forms, it includes IRB approval, it includes equipment and staffing. One of the things that Isabel Bjork, who is incredible, has identified is when you're working with institutions, it's really important to resolve things like equipment and staffing. You need to ship them a toolbox, so they don't have to worry about that, right? You're a PhD student, you want to make an impact in your community, but you don't have the resources to do so. So we'll ship you the thing, and you won't have to do anything, right? The volunteers will come. And this allows you to have a lot less wasted effort. You don't have to spend time setting this up. Another thing that allows you to get a lot of consistent data points is the data pipeline. We basically, we're writing the playbook to set that up for you. So that's stuff like coming with a Starlink terminal to get you Wi-Fi so that you can use the secure web forms, which are HIPAA compliant, to actually input the data. It's stuff like using standardized equipment, because if you have different equipment for different populations, that might skew your data. It's things like making sure that your data is encrypted on a hard drive that is then locked in a safe, which might sound very normal to you, but is not normal to most people. It's things like having somebody like me who can come in and edit that data and send it off to people in a de-anonymized way. And the last thing that is important for scalability is really this harmonization of data. So how do you get a lot of data, which is an input to many of these AI pipelines, which is in the same data format, with the same questions that are asked, with the same methods of collection, and with the same equipment. There's so much time from PhD students that I've talked to that is just trying to get data and trying to get good data and messing with data to get it in the right format to just do the analysis. So that's great. You've got lots of data points. We need to make this accessible to people. So that could be you. It could be people under you, PhD students. So what does Champions bring to that? It brings aligned incentives. So it's super easy to request access, for example. When you've contributed data, that's aligning incentives. It's all in one big data repository, and it's all in the same format. And this is really bringing together people so that you can have an impact bigger than yourself, and you can leverage your effort in a way that is, I think, quite unusual. Now, none of that matters if you don't have security and privacy in place. And that's really important to build and maintain trust. So especially for underrepresented communities, which is one of the main targets for Champions, it's very important to maintain that trust going forwards throughout the data pipeline as well as in general. So everything that we do is HIPAA compliant. Now that's really important, but it takes a lot of time to actually go through and make sure that all the different tools that you're using are HIPAA compliant. It's stuff like, again, putting your hard drive that has your data in a safe, but then you also need it to be backed up. What does that look like? So I'm literally writing a document to make sure that that's documented and approved. It's things like having guidelines around not publishing data that identifies a single person. So all of this kind of is baked into, I think, what I consider to be a model of the future for vascular research, which is Champions and being able to take this toolkit that Champions provides and go out and remove barriers, leverage your effort, collect good data, and share it. And with that, everybody wins, right? You've got your patients who are getting their free screenings. You've got your healthcare providers who are getting an easy-to-use toolkit and allow them to actually make an impact on their community as opposed to just writing papers. Writing papers is great. Medical institutions are getting trained volunteers and are training the next generation of medical workers. And then you've got researchers who are getting really high-quality data. And what does that really mean? It means progress, and it means prevention. It's allowing us to go in and go to somebody that controls the money bags and say, this is a problem, and you should send your money here. That's all. Thanks. I guess, should we open questions?
Informaticist and pediatrician from a woman with a difficult to pronounce last name. Can you please tell me your last name?
Yeah, Zahidi Vash is how you say it.
Thank you.
When I was a kid, we would have substitute teachers in elementary school, and I would know when they got to me, but they would pause. And then I'd say, yeah, I'm present.
Thank you, and thank you for your good humor. I have a Cosmos question, and this goes back a little bit to what we were talking about before lunch when Matt Courier was talking about how to engage with industry and kind of that gap between like academic purity and work that's done for profit. And so, you know, my understanding of Cosmos is that it's like this secure enclave for Epic users. And so at UNC, for example, we use Epic, and we have created our own secure enclave to make sense of all of the information that comes out of Clarity, right? Which is like the hodgepodge of Epic data, all of the things in Epic. Go into this thing called Clarity, and ironically, it is the least clear thing imaginable because it's really, really messy, and so you gotta organize it. And so UNC has done that for itself, and I'm sure that all of our other institutions have done that for themselves, and that creates silos. And so Cosmos, the way they sell it is that it prevents this from happening, because if you are willing to buy in, then you can start to compare across the country. But Epic is a private company, and Epic then owns all of that data, and they have not been like super clear on if you're allowed to publish out of that data or if you're allowed to look at their processes for how they are distributing that data. And so that seems kind of scary, but it also seems like there's a good resource that we could all embrace, except for the fact that like our patient-centered focus in academics is not generally aligned with Epic's money-focused goals.
Yeah.
How do you work through this at Stanford?
Yeah, thanks for asking. So, a few things. Epic we've actually brought up some of the ethical complications too with it, because essentially, you know, maybe this isn't like a big moneymaker for them, Cosmos, but I'm sure it's a big lure for someone to sign on to Epic, right? So they're really making money off of the data of lots of patients, right? Now, they don't own the data necessarily. The institutions and the patients still keep track of a decent portion of that from what we've been told. Maybe that's not the case.
Yeah, that's totally not the case.
Well,
You own your Stanford data and your patients own their personal data.
mhm.
Anything that gets analyzed and put into Cosmos is Epic's. It is very clearly different, just so we're all.
Maybe, yeah, maybe, you know, obviously not with Epic, so maybe I didn't
Yeah, I'm sorry,
get the
but
whole
not
words,
that
yeah.
You as like a single informaticist.
Sure, yeah.
Know these details, I just happen to be really interested in it, and then I'm like really not interested in it. And it's-
Yeah. No, ethically, it's a really interesting issue, and they specifically prohibit you from using it for commercial purposes for good reason. From what I understand, if you were interested in doing and applying it in that way, like they would enter like a different agreement with you and dictate how you would distribute that data if it was for commercial use, or the insights from it. For academic reasons, you have to disclose exactly what you're looking for. You have to show you have institutional IRB approval for it. And they said that they're pretty friendly with that, at least. It's been like weeks since we got access to it, so we're only like learning more about it, and what I showed you is like the extent of us playing around with it. And obviously, there's still much for us to learn about it as well. So I think for academic reasons, it's really helpful. And I think for obvious reasons, if you're interested commercially in that data, I think there's going to be a lot of limitations for it for good reason.
Yeah, I guess I would just warn everybody that Epic is commercially interested in that data. Sure. And there is no promise on any of those documents that they are not going to turn around and sell your hospital's data.
Yeah.
And since data is power, and all of us in academics are trying to figure out how to cling on to power, but also work with industry, it's super complex. Just as you think about talking with your chief of informatics at your place.
Yeah. Yeah, and that's where that number of 270 million, I think, is really crazy, because if you think about how many people are in the U.S., it's like 75 to 80% of the U.S. I mean, it's pretty alarming.
Courier.
This is a great session. We were just talking, I don't know if everybody knows, but Epic, there was an antitrust lawsuit filed against Epic this week. I think Dr. McGinnigal may have filed it, I'm not sure. But, what I was gonna ask is, Epic's like super expensive.
Yeah.
Do we know where the Epic deserts are? We saw like provider specialist deserts and like workforce considerations, and it wouldn't surprise me, I don't know.
Yeah.
But it wouldn't surprise me in the rural place in Mississippi, for example, we might be modeling with these big data sets, but we are blind to what's not in there. So any comments on, is Epic too big, and what about the places that don't have it? Are there Epic deserts?
Yeah, I mean, absolutely. I think that's the biggest issue that we have with Epic, especially those of us who look into health equity. A lot of PEDS FQHCs don't have access to Epic, for example. And if you're familiar with OCHIN, it's an organization that puts out Epic for cheap for publicly funded clinics, or clinics without the resources to buy Epic. That's the way that a lot of these organizations get it, which is why I think their number's so high. But at the same time, I don't know specifically which areas of the country. I can ask some of my colleagues and get back to you when we talk later.
That product you mentioned is called OCHIN?
Yeah.
How many places are live through that?
Our clinic is in Atherton. We have an FQHC for kids, like our Stanford faculty practice.
But that's through Stanford.
No, it's OCHIN. So we don't have, it's not Stanford's Epic. That's a separate clinic. And then we get Epic through partnering with OCHIN. It's not run by Stanford.
But that's a Stanford clinic.
It's funny. So Stanford's faculty, so because primary care and peds doesn't make as much money as other specialties, Stanford doesn't have a clinical enterprise in primary care for the residents. Instead, it's run by Gardner Health. I don't know. Gardner Clinic is essentially what it is. They have some place in San Jose too. So they're the clinical enterprise that we work with in primary care, and we staff it with Stanford doctors. That's the Stanford relationship, but the Epic is not Stanford.
But Epic has a vested interest in this, would you call it again, OCHIN?
OCHIN is like the organization. I think they're that organ, actually.
And they don't just use that. I mean, I would just say, one of the things about OCHIN is there are a lot of different data sources to get those, but one of the drivers is that we're trying to get EHR data sources at really credit health centers and other places.
Yeah.
And that might have to, Epic is one of the big sources of knowledge.
Mm-hmm.
So I do think the value proposition for us in this space is a lot of real world worry, I think, about how big Epic is. Back to your question about is there antitrust issues and issues, that's an interesting question.
Yeah.
But there's deserts where community health centers, a variety of things, are using other things that we might be able to partner with, because again, we go out with our patients
Yeah.
who need us most.
I agree. I mean, if you look at, I bet you a lot of the publicly funded patients that are part of that data set may have come through OCHIN, but at the same time, there's a lot of the country that we're not capturing.
I had a question about Cosmos. Does it look through the media tab? Can it read through the media tab?
It doesn't, to my knowledge, it doesn't get imaging results right now, and I think scanned documents are not included.
Because a lot of our patients also have hybrid models, right? They're not
Right.
always in clinics that use Epic.
Yeah, exactly. So you might get the records in the media tab. To my knowledge, no, it doesn't. This is all like anything that's in FHIR format or line codes.
I would just say, Matt, most of Central California is not on Epic. We have Epic, but every single rural community is not on Epic.
Yeah, especially the independent clinics, I'm sure.
I have a question that has been burning from this morning. All right, so this is for you or for the audience. One of the lowest hanging fruits, I think, in AI is interactive AI with people who are interacting with their charts. I mean, Amazon can tell me exactly what book I want to order next. So why can't Epic or these platforms tell the patients, like, hey, we noticed your last hemoglobin A1Cs were 7. Would you like some information? Like, why isn't there a chat bot in that space?
I mean, I brought it up. There's a few, some that Epic is releasing, and some that a lot of different groups are testing. The fear, at least the fear or the test is, there's going to be so many that questions which ones work well and are not hallucinating. And so, you know, I'll give you examples. When we started doing this in basket, and it's only gone on for a little bit at our place, it goes through and starts to come up with, yes, A1C, but then potential other things. Like, I'm not sure we haven't agreed upon recommendation on what the therapeutic thing should be for this patient. So what at least is happening right now is that what happens is in the retrospective review, they're running it as an in-basket onto questions. And you can imagine where it seems to be better than physicians is it is, as you saw, more empathetic. It writes out a longer note than I might in my in-basket. And patients do respond and seem to like that. But when complex questions are there, it summarizes, at least the tools I've seen, summarize them into unusual scenarios. And the other place I thought it would help would be scheduling. One opportunity seems like, why couldn't we make more equitable scheduling? This person needs to be scheduled sooner, get them here, it's close. It's interesting when we look at it from a health equity lens, just having access to my chart or whatever your tool is one of the other big issues. And so it might start to fill up your open slots with people who aren't in the system as much electronically.
Yeah, I mean, I just don't understand why we're so behind. I mean, I can book my hair appointment wherever I want. I can look at everybody's schedule, all the people who are offering the service, what dates are available. I can pick my day and my time and schedule myself. Like, why can't we do that in medicine?
Yeah, I'll give it to her. I'll just say that we're talking about Epic doing this, but I said this before in this room. When you're in the OR in the cath lab, why are all those tools not available to tell me what the risk of this patient is and what the score is and where my wire is supposed to go and what the radiation is and beep when I use too much radiation? So we're asking Epic to do something that we're not demanding of our other spaces. We should demand them in all the spaces.
So in terms of interactive patient sort of interface, I'm going to move outside of Epic a little bit. I think of EMR and I get a TIA, so I think that's where I am right now. I'm going to move into the radiology space because there's pilot programs right now where actually if they have a sequence of, let's say, increasing aneurysm sizes, it automates and actually generates a notification to the PCP and to the patient. So one of the things that has come into, I guess, question is actual medical legal liability, right? Because a lot of that is resulting from some form of natural language processing in terms of being able to look at the dictation, find keywords, and then classify it into a binary model of yes, it's getting bad, yes, it's not getting bad. So there are some pilot programs, if you go to like RSNA or SIR or any of the large radiology rank and Ray meetings, they talk about that. And it's not in the context of how the public worries about it, like, oh, we're gonna fire all the radiologists. It's not. They're really looking at to see how we validate that, how you catch the like false negatives, for example, and where that boundary is. As of right now, all AI-based programs in terms of binary classification, let's say those other companies I may have listed on my presentation, you must have an overread by the radiologist signed off and certified within the hospital record system, right? And that's for any imaging at that point, not so much for billing, but for medical legal validation. What we don't have is that other piece, the guide that was missed, the CT that had poor quality, the imaging that was not imported correctly, transmitted, acquired, right? That population is there. How many CTs do we get? We're like, oh, that's crap. Like, that's poor timing. There's no contrast, blah, 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 blah. Patient rolled off the table, you know, whatever, right? We have that, and that's not what's being captured. So from the radiology side of things, the ones who are doing these automated sort of like interfacing things, where it's actually relying on that system to capture, that's what they're worried about. So the models are there. We just don't know how to safeguard it for our patients.